The following podcast is part of a certified educational activity titled Teaming Up to Overcome Challenges in the Diagnosis and Management of Non-Infectious Uveitis, Enhancing Multidisciplinary Care in the Biologic Therapy Era. Access the entire activity and complete the post-test at peerview.com/SYZ860. Downloadable slides and practice aids are also available.
Hi, my name is Eric Suhler. I'm an ophthalmologist specializing in uveitis, practicing in Portland, Oregon, and it's my pleasure to talk to you all about how we navigate the diagnosis and management of non-infectious uveitis, the perspective of an ophthalmologist, me. So, start off with a patient case. So this is a 10-year-old boy who came into my clinic a number of years ago on his birthday. Actually went to the cafeteria, picked up a chocolate chip cookie and sang happy birthday to him. He had no known medical history. He was small for a stated age. When I reviewed his chart, it said he was at the 8th percentile for his age in terms of size. It says his knees hurt sometimes, and he was seen by a terrific pediatric ophthalmologist in our town, diagnosed with bilateral uveitis and referred to our clinic. So that brings me to the three main questions patients ask me when they come to see me. What is uveitis? Why do I have it? And what can I do about it? So strictly speaking, uveitis is inflammation of the uveal tract of the eye, which is comprised of the iris, which is the brown, green, or blue sort of shutter to the front part of the eye that gets bigger and smaller with light, that lets the right amount of light get back to your retina, so the iris. The ciliary body, which is the structure behind the iris, which makes the fluid that keeps the front part of your eye inflated, and the choroid, which is the vascular or blood vessel layer under your retina that brings nutrition to the back of the eye. So one of those three layers, technically speaking, is the area within the eye that's inflamed in uveitis. However, generally speaking, inflammation of any intraocular structure can be defined as uveitis. So inflammation of the retina is commonly also defined as uveitis. And it's important to know that 80 to 90% of cases are non-infectious, which means, of course, 10 to 20% of cases may be infectious or neoplastic. And it's our job as ophthalmologists to pick out those masquerade cases and focus in on these 80 or 90 cases that are non-infectious or immune-mediated, which require treatment with anti-inflammatory medications, which we'll talk about a little bit more in a bit. So, uveitis incidence and prevalence and the burden of disease. Well, population-based studies show that uveitis is not common, but it's not rare either. So we think that uveitis occurs in probably at least one case per thousand in the population, or one person per thousand, although there are population-based studies that have showed a prevalence as high as 5 per thousand. There's decreased vision that's present in some series up to 40 to 70% of the time. And severe vision loss can happen in up to 25% of cases that affect the back part of the eye. Uveitis is responsible for approximately 30,000 new cases of legal blindness annually in the United States. And the actual rates are difficult to calculate because uveitis is not one monolithic entity, but as many as 30 different diseases that all are tracked and billed and coded differently. Therapy obviously must be tailored to the cause of the uveitis as well as to the location, whether it be the front of the eye, the back of the eye, et cetera, and the individual patient's preferences. In many cases are associated with systemic inflammatory disease, which makes it super important to be able to collaborate with specialists that are experts in systemic inflammatory diseases, commonly rheumatologists, of course. So when patients ask us, why do they have uveitis, one of the most important tasks that we can do both for differential diagnosis and for deciding what the most appropriate treatment is to classify the uveitis based on the location of the uveitis. And we have, broadly speaking, 4 anatomic classifications for uveitis. There's anterior uveitis, which is inflammation primarily focused in the front of the eye, in front of the lens of the eye. We have intermediate uveitis, which is inflammation primarily focused in the vitreous cavity of the eye, between the lens and the retina. We have posterior uveitis, which is inflammation in the retina and choroid of the eye. So the retina is the film in the camera of the eye, and the choroid is the blood vessel layer we talked about under that. And it goes without saying that inflammation of the retina and choroid, which are the film of the eye, can cause very severe vision-threatening disease. And then, of course, panuveitis is a combination of all three of those things, where we see inflammation in the front of the eye, in the vitreous cavity, in the retina and the choroid, all combined. That's what we call panuveitis. Okay, what are the symptoms of uveitis? Well, again, they vary by the location of the disease and sometimes by the disease subtype. So anterior uveitis, especially acute anterior uveitis, such as might be seen in diseases like reactive arthritis or ankylosing spondylitis, we talk about RSVP symptoms. So we want our patients to RSVP for the clinic if they have redness, sensitivity to light, decreased vision, or pain. And the way we assess the presence and the severity of anterior uveitis, we look for white blood cells floating around in the anterior chamber of the eye. And with intermediate uveitis, conversely, patients may not have pain or redness or light sensitivity, although they often will have decreased vision, What we'll see are floaters or blurred vision or decreased vision, especially if there's macular edema, like swelling in the center part of the retina that we use to read and see faces and do high definition vision. So we look for those inflammatory cells and haze in the vitreous gel and the presence of peripheral retinal inflammation in intermediate uveitis. Posterior uveitis, again, we look for inflammatory regions in the retina or in the choroid, and we can see those clinically with our examination, and we can also see them using specialized imaging technology. And we also may see overlying vitreous cells and haze. And again, pan-uveitis, we see all three. It's the full meal deal, so to speak. So grading uveitis, I already touched on this, but we look for anterior chamber cells. We look for aqueous flare, which is proteinaceous leakage of fluid from the iris blood vessels into the anterior chamber of the eye. Vitreous haze is a very important way that we measure inflammatory activity in the vitreous. And we do that by using our indirect ophthalmoscope, the headlight we strap on our head, and using a concentrating lens to examine the retina. And we grade the amount of blur in that examination using standardized photography that basically tells us, is this 0.5 plus, or is it 1 plus, 2 plus, 3 plus, or 4 plus, where we can't see anything in the back of the eye. We look for inflammatory retinal and choroidal lesions with our exam and with imaging. Of course, we measure vision using a standardized Snellen eye chart, and we measure intraocular pressure using a tonometer to measure the degree of pressure in the eye. Between 10 and 21 is normal. Anything above that is a problem. So why is this important? Well, my colleagues at OHSU published this paper a number of years ago in the Journal of Ophthalmology, where they clearly outlined the importance of accurately diagnosing the anatomic classification of uveitis and how that helps us make a diagnosis of what was previously thought to be a rare disease, tubulointerstitial nephritis and uveitis. So Frederica Mackensen, our former fellow, working with my colleague Justine Smith and my colleague Jim Rosenbaum, who you'll be meeting shortly, looked at all the patients that had ever come to our uveitis clinic and looked at this entity we call TINU, or tubulointerstitial nephritis and uveitis. And looking at all the patients that had ever showed up, about 2,000 at that point in time, this was in 2007, we found that about 1.6% of people that were seen in our clinic had TINU. Not very common. But if you looked at all the people who had bilateral sudden onset disease that was in the front of the eye, acute anterior uveitis, all of a sudden that number became 10%. And then if you looked at all those people who were less than 20, it was about a third of the patients. So what this really shows is making an accurate anatomic diagnosis, knowing that this was a sudden onset bilateral process in the front of the eye, especially in a kid. TINUs might be the most common diagnosis we see. So accurate diagnosis is key for differential diagnosis, also key for helping us decide how to treat patients. So we talked about the what is this question. The next question people have to me is, why do I have it? Well, how do we figure that out? Well, the most important tool in the bag of a uveitis specialist, an ophthalmologist specializing in uveitis, or really a specialist in any area in medicine, is taking a thorough and complete medical history. That includes reviewing the medicine list, that includes reviewing all the past medical problems the patient may have had, any surgery, has there been any trauma, has there been any travel history, do they have any pets? I mean, we can go right down the list of all the important questions we ask. Of course, we do a thorough eye exam where we check vision, we check pressure. We look carefully at the front of the eye, the vitreous, the retina, and the choroid to try to accurately classify the disease. We do targeted imaging. We do targeted laboratory and diagnostic testing, not just sort of a shotgun where we order every test in the book, but testing that's appropriately targeted to the information we've gained by doing the history, looking at the eye, and then doing a good physical examination as well. And then, of course, when indicated, referrals to additional specialists, commonly rheumatologists. Okay, so we talked before, infectious, neoplastic, or cancer are reasons. Sometimes those can present in ways that look like uveitis. I won't sort of overly belabor the point of how we diagnose a patient with a lymphoma, which is a condition that was predominantly seen in people who are much older with chronic, what looks like vitreous inflammation, but really the vitreous is infiltrated with inflammatory cells. Ophthalmologists who are well trained and know what to look for can usually pick that out. And if we're not sure, we at least maintain a high degree of suspicion, and we do diagnostic testing, which will include taking fluid out of the eye and looking at it under a microscope. Infectious masquerades are things we see a little bit more commonly. Viral infections from things like herpes simplex, herpes zoster, CMV are things we see. They have characteristic clinical features like high pressure or iris defects that we can identify appropriately, and if we're not sure, we can take fluid out of the eye and we can identify it using direct tissue assays like PCR. One of the things that I always teach our residents is how important it is to dilate the eye and do a complete examination of a patient, a newly referred patient with uveitis, because there are patients who get referred with anterior uveitis. When you dilate the eye, you see a characteristical retinal scar like that describes or that identifies the patient as having toxoplasmosis, or peripheral retinal lesions that describe acute retinal necrosis from one of the herpes viruses. And so those are obviously treated very differently than in an inflammatory case, but those are rare things. So we talked about the three questions, right? What is it? Why do I have this? What do I do about it? Well, now we're down to the what do I do about it part. And I tell our patients we have three choices. We have drops, we have shots, and we have pills. Now, shots these days include short-acting intravitreal injections and longer-lasting implants that can either be injected into the eye or sewn into the eye. But I guess another way of looking at this is drops, local therapy, and pills. So how do we decide? Well, I'm going to mainly talk about drops and shots, and Dr. Rosenbaum gets the fun job of talking about the systemic medications that we commonly use other than oral steroids. In terms of what do I do, drop shots and pills are our choices. Well, drops are a great choice, right? So one of the common sayings that Dr. Rosenbaum is fond of is the punishment has to fit the crime. So if the crime is inflammation in the front part of the eye, a self-limited, severe acute anterior uveitis, drops are great. So why would you bring out the elephant guns to kill a mosquito, right? You use drops to treat severe inflammation in the front of the eye because drops are great for severe inflammation in the front of the eye, especially for a self-limited disease process like most uveitis from ankylosing spondylitis, reactive arthritis, other seronegative spondyloarthropathies. So we use eye drops aggressively. We use them every hour. They work great. They work most all the time for severe flares of acute anterior uveitis. Now, for a chronic anterior uveitis, they may not be the best choice. But for an acute anterior uveitis that may be self-limited, we can help it along, help it get faster really quick with topical steroids. We use dilating drops or mydriatic drops, cycloplegic drops, if you will, to dilate the pupil, keep the inflamed iris from spasming and causing the patient pain, and also to keep scar tissue from forming around between the iris and the lens of the eye. Regional corticosteroids or steroid injections, we'll talk about those a little bit more in a second, and I use oral corticosteroids all the time. One of the reasons patients are referred to me sometimes is because referring doctors will say, I need something stronger than steroids. And I say, hey, there is nothing stronger than oral steroids. But oral steroids, when taken for inappropriately long periods of time, I tell patients they will reduce the quality of your life. You will gain weight, you'll be irritable, you won't be able to sleep, you'll be at risk for diabetes, you'll be at risk for bone fractures. So they certainly reduce the quality of your life, and if you take them for too long, they reduce the quantity of your life. So steroids are the most dangerous drug we use, and so we use them to put out fires. They're great drugs for that purpose, but we don't want to depend on them for years and years and years. We want to sort of move along to steroid-sparing drugs. They can get people off oral steroids because oral steroids can hurt you if you take them too long. For long-term ongoing therapy of chronic anterior uveitis, we don't want to depend on drops, and I'll talk a little bit about one of the reasons for that, which is a clinical trial that was done in children with juvenile idiopathic arthritis by my colleague Jennifer Thorne at Johns Hopkins. And she looked, without totally belaboring the point of the study, she looked at children who are well controlled because active inflammation in and of itself causes cataracts. But what Jennifer did is looked at all of her patients with juvenile idiopathic arthritis that were on chronic corticosteroid drop use. And what she found is people taking 4 drops a day of corticosteroid for a period of a year, 1 in 6 will develop a cataract during that time that's visually significant. Whereas if they're on 3 drops a day or less, it was 1 in 100. 2 drops a day, the risk was basically 0. So what we learned from that is chronic corticosteroid use at a dose higher than 2 or 3 drops a day puts people at what we would consider to be an unacceptably high risk of cataract, especially children who we really don't want to give cataracts to and have to remove their cataracts at a young age. The other risk of topical steroids over the long term is pressure elevation. And one of the common things or common terms that we use in describing pressure elevation in ophthalmology is we describe certain patients are steroid responders. In other words, when we give them steroid eye drops, their pressure goes up. And one of the things I've commonly said is everybody is a steroid responder. It's just a matter of how much steroid is it going to take. When drops aren't enough, and for intermediate posterior and panuveitis, which is inflammation behind the lens of the eye, in the back of the eye involving the vitreous, the retina, and the choroid, drops are clearly not enough. So we have to use shots or pills, right? Drops, shots, or pills. Drops are great for front of the eye. Shots are great for inflammation in the back of the eye. But again, as my mentor Bob Nussenblatt used to say when I was a fellow at the NIH 20 years ago, periocular steroid injections are a bridge to appropriate therapy. They put out the fire and they get the inflammation under control, but they're not appropriate therapy in and of themselves, because if all you do is give shots over and over and over, the inflammation gets better, it gets worse, it gets better, it gets worse, and there's decline that can occur in those periods in between the shots where the inflammation's more severe. They also put patients at a very high risk of developing cataracts and elevated pressure. So we use them to get out of trouble, but we don't want to depend on them exclusively as a method of treatment. So in a clinical trial that was done a number of years ago by many of the people that I've already spoken about by a group sponsored by the NIH, compared long-lasting steroid implants to systemic immune suppression. I won't belabor the study. Suffice it to say that putting a pellet inside the eye that leaks out steroid for 3 to 5 years works really well for controlling inflammation. 100% of people get cataract. 70% of people get glaucoma. 40% of those people need glaucoma surgery. And as it turns out, using systemic immune suppression of the sort that Dr. Rosenbaum will talk about works pretty much just as well. In fact, it works out better at 5 to 7 years for visual acuity than putting in a steroid implant. So that was important for us to know. So steroid implants work great, steroid shots work great, systemic immunosuppression also works great. And it's really just a matter of tailoring the approach to what the patient needs. If I have to use oral steroids, like I said before, people want stronger therapy than steroids, and I say there isn't any. Steroids are great, steroids work well, they work fast. They're fantastic drugs for putting out a fire, but you don't want to use it to keep the fire out forever. You want to sort of put people on high-dose steroids, get the inflammation under control, and then move along to something that can hold the inflammation under control long-term that has less side effects than prednisone. Again, we talked about weight gain, irritability, difficulty sleeping, bone fractures, infections, diabetes, high blood pressure. I have a slide in my lectures where basically I list the side effects of prednisone, and it's like tiny font and it's an entire page, and that's just meant to sort of illustrate to our trainees, these are the most dangerous drugs we use an appropriate dose. I start people on 40 to 60 milligrams most commonly. 80 would be the max that I would give somebody orally, and I try to taper them off corticosteroids within 3 months using steroid-sparing immunosuppression as my adjunct to do that. And if I'm unable to taper somebody to less than 10 milligrams within 3 months with the assistance of a given immune modulating drug, be it an antimetabolite like methotrexate, azathioprine, mycophenolate mofetil, I either add a drug or I switch drugs or I move on to the next thing like a biologic. So we talked about the patient case. We kind of forgot about our patient, but I'll tell you what the birthday boy looked like when I saw him. He had pretty severe inflammation when I saw him. 2025 on the right, 20/150 on the left. He had 2+ anterior chamber cell, like I said, how we count with our slit lamp beam on the right, and 1+ anterior chamber cell on the left. He had what we thought was neovascularization of the iris at the time. Turned out his iris vessels were just really, really inflamed and angry and swollen because his inflammation was so severe. His retinal exam was pretty hazy but grossly normal to my examination. So we gave him lots of topical steroids, increased his topical steroids. He was already on topical steroids. He came back to see me 6 days later, and he had 3+ anterior chamber cell in both eyes, so very severe disease. His vision had dropped all the way from 20/25 to 2400 in the right eye, and had gone from 2150 to 2200 in the left. So he's basically, at this point, legally blind over the course of a week. And we did diagnostic testing, and these are the pictures that we took that day when he was, I suppose, now 10 years and 9 days old. And as you can see, the picture on the right is an OCT. We talked about that in vivo histology level of definition in terms of seeing what's going on in the retina. And the picture on the left is his right eye. So it's quite common in ophthalmology. We show the right on the left and the left on the right because it's as if I'm looking at the patient. If I'm looking at you, I see your right eye and your left eye. So that right eye, that heat map on the top left of my graph right here shows just basically it's red and white all throughout the center, which just shows that the thickness of the retina is through the roof. I think it's about 1,000 microns. The normal thickness of a retina is 250 to 300 microns, depending on the imaging technology you're using. And you can see the picture on the bottom left of my slide here. He's got just massive macular edema, and there's this ginormous, basically serous detachment of the macula with probable fibrinous sort of debris under the retina. It's just incredibly swollen. That's why you can't see. He's 2400 because of this. If you look at the left eye, it's a little bit less dramatically thickened, but there's this massive subretinal fluid that's separating the retina from the retinal pigment epithelium and the choroid underneath, and he's 2200 in that eye. So we basically brought out the big guns. We put him on, I believe I put him, he weighed 21 or 2 kilos. I put him on 2 milligrams per kilogram of oral steroid, which is, I think, 45 milligrams of prednisolone syrup. Within 2 weeks, I had started him on methotrexate as well. I had referred him to my colleague, the pediatric rheumatologist across town, who did a lot of diagnostic testing. And we found that he, in point of fact, was HLA-B27 positive, but was ANA negative and rheumatoid factor negative. So he actually didn't have JIA, which is what I suspected based on his small stature and his knee pain. There was no evidence to support him having JIA. They did a number of other tests based on the severity of the retinal detachment. Sometimes children with cat scratch disease can have this. That was negative. He was tested and found to be negative for syphilis. We checked a urine beta-2 microglobulin and a urinalysis thinking about TINU, tubulointerstitial nephritis and uveitis, that was also negative. So this kid actually has idiopathic, very severe chronic bilateral anterior uveitis, or at least that's what he had at that time. And we put him on methotrexate, tried to taper his corticosteroids, and you can see here are his pictures at 2 and 4 weeks after starting high-dose corticosteroids, and the 2-week marks where we started methotrexate. And you can see that his macular edema fairly dramatically improved in short order, and his vision came back into the 20/30, 20/40 range over this period of time as well. 3 months after he started oral steroids, on tapered to 0.5 mg per kg, I believe he was on 12 to 15 milligrams of prednisone a day. He had a severe bilateral flare. His pressure went to 46 in the right eye. Referred him to a glaucoma specialist. Fortunately, he didn't need surgery. He was able to be treated medically. We boosted his oral pred at that time and started him on adalimumab, and he was quiet on this regimen for 2 years. Then he subsequently stopped medicines due to insurance issues and was lost to follow-up. Came back the following year with a very severe in extremis sort of flare. We started him on infliximab at that time, and he's been quiet ever since. And now he is in high school, and he's been quiet for a long time and actually has a driver's license and drives around town and is doing just great. So what are the indications for indicating non-corticosteroid systemic immunomodulatory therapy? Well, there's a big group of experts that got together and sort of debated this issue and came out with this issue, and came out with a consensus statement called the FOCUS guidelines, and some of those are displayed on the slide right here in front of you. Well, so ocular and anatomic features that we consider, acute disease that's sight-threatening. I always think of the quote from Jack Nicholson in a famous movie where he was made to sort of describe the difference between danger and grave danger, and he said, well, is there any other kind than grave danger? Well, we talk about, disease that affects the posterior segment of the eye, in intermediate posterior and panuveitis, I think almost by definition is vision threatening, and so it requires chronic therapy with non-corticosteroid systemic immunomodulation, in my view. Certainly bilateral posterior segment involving disease is something we strongly consider immunomodulatory therapy for. If they have an exudative retinal detachment, you saw this kid that I just showed the picture of, his entire retina was detached by inflammatory fluid. We're going to treat those people more aggressively because we know that swelling in the macula can irreversibly damage vision. It's the most common cause of permanent vision loss in uveitis patients. Again, back of the eye, involving the macula, binocular, all reasons we treat people more aggressively. Steroid shots don't work. People can't take steroid shots, or we just don't want to give people steroid shots forever. We give them immunomodulatory therapy. Just makes sense, right? Systemic failure. So like I said before, prednisone's the strongest drug we use. Sometimes people can't tolerate it. Sometimes people have breakthrough flares on unacceptably high levels of corticosteroid. So when I'm tapering people down from that 60 to 80 milligram dose all the way down to 10 milligrams a day and they flare along the way, especially if it's after 2 or 3 months of taking a given immunomodulatory drug, time to move along and move to the next thing. We're pretty aggressive about that. And certainly we're not willing to tolerate more than 10 milligrams of prednisone a day. Personally, I'm not willing to tolerate more than 5 milligrams a day. And we would love to have all of our patients on 0 milligrams a day. Bad disease, bad vision, bad inflammation, treat with serious drugs. That's pretty much what we do. So in summary, the differential diagnosis for uveitis is critically important and critically dependent on a careful examination and targeted testing. We've talked about that. Anatomic classification, super important. Uveitis is not a monolithic entity caused by 30 or more different disease processes. We got drops, we got shots, we got pills. Ophthalmologists are awesome at giving drops, really awesome at giving shots. Comfort with the third is variable, right? So I'm an ophthalmologist who has specialized training in uveitis. I'm happy to use a lot of these immunosuppressive drugs, but if you're not comfortable with using immunosuppressive drugs or choosing the one you need, enlist your friendly neighborhood rheumatologist right down the street and let those folks help you, because they're the pros at this skill. Systemic steroids, they're easy to use. We're comfortable using them. They're the most dangerous drugs we use. Got to get people off high-dose oral corticosteroids. Put them on steroid-sparing immunosuppressive therapy. Enlist your friendly neighborhood rheumatologist if you need them. I remind myself all the time, as good as I am at prescribing immunosuppressive drugs, I am not a rheumatologist. And many of my patients have systemic inflammatory disease that's subtle and that I may not pick up on my exam or my history, that the rheumatologist can be of immense help with in not only treating the patient with immunosuppressive drugs, but in identifying the disease that exists, and so that the patient can get the best possible care. So Teamwork makes the dream work. I'm happy to be part of the team taking care of uveitis patients, and I will now yield the floor to my colleague, the rheumatologist.
My name is Jim Rosenbaum. I'm the chief of rheumatology at the Oregon Health and Science University, and sometimes I masquerade as an ophthalmologist. That's a long story. It has to do with some rats that were supposed to get arthritis, but they got uveitis instead. I want to follow up on what Dr. Suler told you by beginning with another representative case, talk about the differential diagnosis of uveitis from a rheumatologist's perspective, and then talk about the treatment options where a rheumatologist might be able to assist an ophthalmologist. So the case is a young man, 23 years old. He had symptoms of floaters and mild eye redness for a couple of months before he consulted with me. His acuity wasn't bad, 20/30 on the right, 20/25 on the left, and his pressures were just above normal. But he had a lot of inflammation. He had 3+ cell in his anterior chamber. He had 2+ cell in his vitreous. He had some haziness in his vitreous. And most of all, his disc was neovascularized. He was growing new blood vessels at the back of his eye. So for the next 24 months, we treated this patient with a variety of medications that included oral prednisone, subcutaneous methotrexate, cyclosporin, topical corticosteroids, and 4 different drops to control his intraocular pressure. On that regimen, his acuity maintained pretty well, but he was still actively inflamed, and it was a delicate balance because the neovascularization would come and go, the pressure would go up, and there wasn't much more that we could do. And on top of that, he was getting cushingoid and he had hypertension. So how should we treat this patient? I'm going to leave that waiting for a moment so I can give you a little bit of background. Dr. Suler told you the differential diagnosis broadly of uveitis. My job is to talk to you about the systemic immune-mediated diseases, as well as ocular syndromes and idiopathic, such as the 10-year-old boy whom Dr. Suler described. So for rheumatologists, you should know that there are a number of syndromes that simply involve the eye and rarely involve outside of the eye. They have wonderful names like sympathetic ophthalmia, pars planitis, serpiginous choroidopathy, acute multifocal placoid pigmentary epitheliopathy. All of these diseases, as best we understand, are immune diseases. The immune system is causing these diseases, so they're important for you to know about. Dr. Suler told you about a child who had idiopathic uveitis, and idiopathic, of course, is not a very satisfactory term because it means that we are idiots. We don't understand, and sometimes that's conveyed to the patient as well. It would be nice if idiopathic uveitis was not very common, but it is common. And if you read series from academic centers, usually idiopathic uveitis is around 30%. I looked recently at my own clinic, and 70% of my most recent referrals all had idiopathic uveitis. I do want to give a shout out to some recent research that we're doing. It was published this year, 2021, in the American Journal of Ophthalmology, and we're trying to look at the gene expression profiles of patients to see if we can better assign a diagnosis to patients with idiopathic uveitis. But let me focus mostly on those diseases that a rheumatologist sees in his or her practice, because there are many systemic rheumatologic diseases that are associated with uveitis. It's almost as if the eye and the joint have a special kinship. And in some of these diseases, like Behçet's disease, the uveitis is often the most important aspect of the disease. In other diseases like ankylosing spondylitis and reactive arthritis, uveitis is very common. 30 to 50% of individuals with those diagnoses in a lifetime will develop uveitis. Sarcoidosis, it's about 30%. And then there are other rheumatic diseases like systemic lupus, for example, where uveitis occurs, but it's rare. Uveitis has been reported in rheumatic fever, but it's rare. In fact, if you make a list of all the systemic diseases that can be associated with uveitis, there are very few. Multiple sclerosis is an example, an entity called Vogt-Koyanagi-Harada syndrome is an example. Very few that don't cause arthritis or potentially cause arthritis along with the uveitis. So Dr. Schuler's already introduced to you how we treat uveitis. And he's gone through the corticosteroids and their various guises, their various approaches, the regional approach, the topical approach. My job is to tell you, as Dr. Schuler forewarned you, about the other ways to treat uveitis with pills or systemic immunosuppression. Those would be antimetabolites, what we call calcineurin antagonists, alkylators, which we rarely use nowadays, and finally the biologics. So before I get into specifics, let me tell you that I approach a patient with uveitis using a bunch of cliches, I confess. And Eric shared with you the cliche that I think I probably use most commonly, and that is the punishment should fit the crime. So every medication which we prescribe is a punishment. It has risk, it has expense, it has inconvenience. On the other hand, if your vision is being robbed from you, that truly is a crime. So if the disease is mild, the punishment should be mild. If the disease is potentially blinding, we're going to call out our strongest armamentarium to combat it. I also like to say that the least amount of medicine is the best amount of medicine, because the more medicine we give, the more toxicity we're likely to encounter. So it's a balance. Life is a balance, and sometimes we want to give lots of medicine, but if we can get by with it, we'll get by with the least amount of medicine. Dr. Schuler also told you about the fire of uveitis, that Bob Nussenblatt said that corticosteroids are a bridge, and we're putting out the fire, and that's what I say as well. Prednisone is like extinguishing fire with water, but we usually don't completely extinguish the flames. And so when we stop the prednisone, we don't stop abruptly, we back off slowly, and that is true whether we're using topical corticosteroid or oral corticosteroid. And finally, I like to say to the patient sometimes, think of me as a waiter or a waitress. I'm here to serve you, and my job is to describe what's on the menu, but it's your job to choose what you want, how you want to be treated, because ultimately it's your preference, and it's your body, and it's your eyes, and it's not intrinsically wrong to prefer the halibut to the steak or to prefer the steak over the fish entree. Everyone is different, and I'm only here to describe. It's a little bit of a way to say shared decision-making is a good way to go. Now, as Eric told you, corticosteroids are our very best medicine and our very worst medicine. Lots and lots of toxicity from the long-term use of corticosteroids. So antimetabolites have a corticosteroid-sparing effect. And the major choices are methotrexate, azathioprine, mycophenolate. Rarely we use one called leflunomide. They're all pretty much interchangeable. Different groups, I think, have different preferences. Since I'm a rheumatologist and we use methotrexate so commonly for rheumatoid arthritis, methotrexate has been around since the 1950s. It's relatively inexpensive. It's relatively well tolerated. I usually use methotrexate as my go-to drug. I want to give a shout out to a study that Dr. Schuler participated in called the FAST study. It's especially a great study that compared the efficacy of methotrexate with the efficacy of mycophenolate in the treatment of patients with uveitis. It was a good enough study that it made JAMA. Not many of our studies go into general journals as this one did. And the concept was, which is better, methotrexate or mycophenolate? It turned out that statistically, neither was better. But if you went beyond the statistics, the methotrexate was a little bit better. And if you looked at certain subsets, those patients who had posterior panuveitis, methotrexate was statistically significantly better than the mycophenolate, and methotrexate is a fraction of the cost. But again, everyone is different, and I wish we had a better way of choosing right off the bat which one is the best drug. We can't. When I started doing this in 1985, cyclosporin was often the first drug which we would choose. It's a calcineurin antagonist, and now there's a more modern version that also attacks the same pathway called tacrolimus. I think that these drugs, because of the hypertension and other toxicities, are still good drugs to treat uveitis, but they're not as popular as drugs like methotrexate and mycophenolate. Eric mentioned the FOCUS study, and I was one of the organizers of the FOCUS group. We had nearly 150 uveitis experts worldwide who contributed. 44 of us met in London, and we discussed and ultimately published what we thought were good recommendations, and Eric reviewed some of those in his talk. There are some forms of uveitis where we don't move up in a stepwise fashion, as I did in the patient whom I described at the start of my talk. And those two diseases especially, where we have a low threshold for starting anti-TNF therapy, a biologic therapy, would be Behçet's disease and JIA. And the reason for that is those diseases can be blinding, and those diseases typically respond dramatically to biologic therapy with anti-TNF. It is incredibly effective. And the biggest change, which I have seen in my practice over 36 years, I think, is the gratification that we now get in treating two entities, Behçet's and JIA, which previously often were catastrophic in terms of visual acuity. Dr. Suler was the senior author on a study called Visual 1. And Visual 1 was published in the New England Journal of Medicine. It was a randomized controlled trial looking at the efficacy of adalimumab for the treatment of non-infectious, intermediate, posterior, or pan-uveitis. And the endpoint in this study was how long did it take the subject in the study to fail to have active inflammation. So everyone got loaded up on prednisone, and then the prednisone was withdrawn, and it turned out that there was a statistically significant benefit to having adalimumab over the placebo. Not too surprising. Now, uveitis, as Dr. Suler said, many different diseases, many different guises, and so how do you formulate an outcome measure to incorporate all those different diseases? Well, in the Visual 1 study, they looked at anterior chamber cell, vitreous haze, visual acuity, and new chorioretinal lesions. And you could fail by any one of those four parameters. And it turned out if you looked at those parameters individually, each one was statistically significantly better if you were receiving adalimumab over placebo. Now, in the Visual 1 study that was in the New England Journal, you had to have active uveitis at the start, got on corticosteroids, quieted down, and then you failed. In the Visual 2 study that was published the same month, but in the Lancet, you started off with inactive disease. You still went on a steroid taper. And again, the endpoint was the time to treatment failure. And again, adalimumab was clearly superior to the placebo. But I want to call your attention to something very important in both the Visual 1 and the Visual 2 study. And that is, while adalimumab worked, roughly 50 to 60% of the time, patients still failed. And why was that? I'm going to come to that in just a moment. So again, our hero, Dr. Suler, has recently published a paper that is now in press on the long-term follow-up of the patients from the Visual 1 and Visual 2 studies, called naturally Visual 3. Visual 1 and Visual 2 were very rigid as to how you would use the corticosteroid. You couldn't increase the topical steroids. You couldn't increase the oral steroids. You couldn't give a local injection. What happens if you give a little bit of leeway? You let doctors decide and patients decide how to treat. Well, in the graph that I'm showing now, in the data from Dr. Suler's paper, you see that patients who started out and they were active initially and then enrolled in Visual 3, after 150 weeks, more than 80% were well controlled. And if they were inactive initially and they were enrolled in Visual 3, more than 90% were controlled. In other words, adalimumab is an incredibly effective drug if you are a little bit lax with the guidelines, lax compared to Visual 1 and Visual 2, and allow a little bit of corticosteroid, either topically or by injection, or even a small dose orally for additional control. It works incredibly well. There also is a really important study that was in the New England Journal called the Sycamore study. And the Sycamore study was for the uveitis associated with juvenile idiopathic arthritis. And again, when I started out in 1985, that was a blinding disease. The Sycamore study took children who had failed methotrexate. They were not adequately controlled with topical corticosteroids or methotrexate, and randomized them to either get adalimumab every other week or placebo. This study was stopped prematurely because it was so clear that adalimumab was superior to the placebo. And subsequently, the Food and Drug Administration in the United States approved adalimumab for children over 2 years for any form of uveitis, not just JIA. It's important to remember that there are other biologics that could be considered. Dr. Suler's patient benefited from infliximab, which is a TNF inhibitor given intravenously. Golimumab is a TNF inhibitor monoclonal antibody that can be given subcutaneously or intravenously. Certolizumab seems to be effective in preventing attacks of uveitis in patients with spondyloarthritis. Certolizumab is another monoclonal antibody that has polyethylene glycol attached to it, and that pegylation allows it to not cross the placenta, so arguably it is safer during pregnancy. Etanercept is a fourth TNF inhibitor, or a fifth TNF inhibitor, which is a soluble receptor and probably is not as effective as the monoclonal antibodies. And now we're having biosimilars, and the biosimilars have not been specifically studied for uveitis, but in theory they should be just as good as the other TNF inhibitors. The advantage of adalimumab is that it is the only one that has achieved FDA approval, and therefore when you're dealing with a third-party payer, it's much easier to get approval. Down the pike, there are lots of other things that are being studied, being examined. The JAK inhibitors like tofacitinib have the advantage of being oral. One study is studying intravitreal injections of an mTOR inhibitor called sirolimus. And another company is studying an intravitreal IL-6 receptor inhibitor called tocilizumab. There are many different cytokines, different adhesion molecules, different cellular subsets, any one of which could be targeted by a monoclonal antibody. So what happened with our patient, that 23-year-old man? When I started seeing him, adalimumab was not an option. It had not been FDA approved. But once it became approved and he was having toxicities from the corticosteroids and the cyclosporin and the other medications, we stopped the cyclosporin and instead started him on adalimumab. On that regimen, he was gradually able to completely stop prednisone, completely stop topical steroids, make his glaucoma regimen just a single drug, brimonidine, and he was without inflammation and without side effects, and 2020, 6 years later, with follow-up. So the treatment for some forms of uveitis is pretty scary to ophthalmologists. You don't see a lot of patients whom you need to immunosuppress. That's what rheumatologists do very routinely. Rheumatologists are comfortable with that. They are potentially helpful in the differential diagnosis, and I'm confident that if you can partner with a rheumatologist, you will be better able to administer immunosuppression. Thank you.
I knew something was very wrong with me when I started running into the walls. I remember one Friday morning going to the eye doctor because my eyes were red with a strong sensitivity to light and severe pain. I couldn't even open my eyes. My eye doctor at the time prescribed some eye drops to reduce the redness and the pain, and he thought it was some sort of eye injury, but he did not refer me to a specialist, run any tests, or knew what was causing the problems. Almost a year went by with me having eye problems and my doctor prescribing contact lenses that did not work like they did in the past. My eye doctor will give me contact lenses to take home and try, but they just didn't work. After all the frustration and my vision deteriorating each and every single day, and my husband insisting that I go see a different eye doctor, I decided to make an appointment with another doctor in town. In the spring of 2015, I visited a new doctor to whom I explained my vision problems, which I had at that point for almost a year. He ran about 5 different tests, and in one of those tests, he was able to determine that my vision was 20/50, legally blind, and that the back of my eye did not look normal. After looking at the pictures, he said I needed to see a retina and macular specialist. I was referred to a third doctor. The retina specialist ran some tests and determined that the eye inflammation and the eye pressure in both eyes was so severe it could lead to permanent vision loss if we didn't do something aggressive to stop the inflammation in both eyes. He put me on 80 milligrams a day of prednisone for 1 week, 60 milligrams the second week, down to 20 after we reduced the inflammation. I visited him a week after, and he mentioned that he had reached out to Dr. Rosenbaum at OHSU KCI Institute, and that he had agreed to see me. The doctor explained that Dr. Rosenbaum was one of the leading researchers in the area and that he could help me figure out my vision problems. Then he set up the first emergency appointment to see Dr. Rosenbaum at the KCI Institute. My first visit to Dr. Rosenbaum's office, which is about 4 hours from my house, was nerve-wracking. I did not know what my options or possibilities could be after almost a year of inaction due to poor advice by my previous eye doctors that almost left me blind. After many visits to Dr. Rosenbaum's office, and after many eye exams and many eye pressure tests and many eye imaging sessions, I quickly learned the name of the disease, uveitis, a word I never heard or knew before 2015. One of the many things that worried me, my family, and my doctors the most was the high dose of prednisone over a long period of time due to the adverse side effects, such as weight gain, moon phase, and facial hair, and all the other side effects that are invisible to the naked eye, like osteoporosis and high risk of infections, etc. After learning about the disease and the medical treatment side effects, my family and I made it a goal to educate ourselves so we knew what Dr. Rosenbaum and the fellows at OHSU were talking about. One of the things that I did to help me reduce some of the well-known prednisone side effects was to stop salt, sugar, and carbohydrates consumption. I drank 2 liters of water a day, and I ran or hiked on average 4 miles a day. I learned the importance of changing my diet and incorporating potassium and vitamins, especially vitamin D, into my diet, so water retention and weight gain could be delayed for as long as possible. During each visit to the KCI Institute, I would sit with Dr. Rosenbaum and the fellows at OHSU to discuss the treatment options and how the medicine was working or not working. During the office visits, the doctors will ask me how things were progressing, how the treatment was working or not, or affecting me overall. Each visit, we will go over the good, the bad, and the ugly of the disease, the medicine, and my body's response to the treatment. My doctor's and family's goal was to find the proper medication to stabilize the condition with minimal side effects. But of course, that's easier said than done. My daily treatment routine included 3 eye drops on both eyes of dorzolamine, latanoprost, and brimonidine. along with a high dose of prednisone and vitamins to reduce the inflammation, slow down the disease, and stop the vision loss. However, these eye drops left me with glaucoma in the left eye and cataracts in both eyes. But I was not worried about it because I was part of the treatment plan and decision making along the way, helping me, my family, and my doctors make educated decisions about my care and possible outcomes. In 2017, I had cataract and YAG laser surgery in both eyes to remove the damaged lens and the fluorescence caused by the medicine. I also had glaucoma eye surgery in the left eye due to the high inflammation that could not be reduced with the eye drops. Our goal was to fine-tune the medicine, control the inflammation during the early phase of the disease. The prednisone, the eye drops were increased or decreased depending on what other medication was being incorporated into my medical treatment. One of the main concerns was the cost of the treatment, which could be in the thousands of dollars a month when using some of the newer medications. I was on eye drops, prednisone, antimetabolics, and finally a TNF blocker, the only drug that did not cause any issues and provided me with the stability and hope of a more normal life. This TNF blocker became an option for me once I learned that the company offers a savings card that could make the monthly dose almost free when paired with my health insurance. As a strong believer of self-accountability, I was willing to do anything to better my treatment outcome. My doctor and patient relationship became more conversational. The doctors and I will discuss how each medication could benefit me or affect me, and what I was doing to help reduce all the side effects. I understood that medicine is an art, and I will need to be part of that solution by changing my life habits. With that in mind, I will read everything I could find about the disease. I will discuss how those medicines will interact with each other. How I started to exercise, meditate. I changed my diet to improve the treatment outcome. Uveitis forever changed my life. I can no longer do some of the things that I once did and took for granted. One of my favorite summer activities was to backpack and swim in glacier water lakes around the Pacific Northwest. However, due to the glaucoma eye surgery and the shunt placed in my left eye, I can no longer venture out doing any high-impact freshwater sports. That's a small price to pay for having the ability to see again. Uveitis affected me in many more ways, but I made every effort to continue my life as normal as humanly possible. I continued my studies and finished my master's degree in 2019. As a self-employed person, I have to be out in the community, visiting people, networking. Still, sometimes I'll say hi to people, but I couldn't recognize their faces if they were not within 5 feet distance. I also developed some type of color deficiency, which makes games like Parcheesi more challenging for me to play. And prednisone left me with a prematurely aged skin. Uveitis forced me to learn about the immune system and ways to boost it. It taught me how to exercise, diet, utilize vitamins, get good sleep, refrain from alcohol and smoking to help me improve my immune system. Although I don't do this 100% of the time, I try my best every day to keep the routine going so I can have a better shot at beating the disease. I communicate with my doctors, and I learned to be an active participant in my treatment. Emotionally and mentally, I'll go through ups and downs, but I know I have the best teams and family helping me and giving me the support I need during a medical crisis with no known cause. Since my diagnosis, some of my takeaways from my medical experience have been me becoming an active participant in the doctor-patient relationship and partnership in order to have a better treatment outcomes. I understand that doctors are medical experts, but I know my body. I know what works, what doesn't work. I know I must be an active participant in the design and the treatment goals. I know that there is no magic pill that can fix me, but instead, I must change from the inside out and practice good health habits that, coupled with medicine, will help me increase my chances of better health.
You and I used to play basketball together, and you know, when we played, a basketball team is better with teamwork. Someone's got to set a pick, someone's got to dribble the ball and pass the ball. No question that there's a gestalt, right? The team is better when it works together. And I think the same is true with medical care. But why is it so hard? What are the obstacles to getting an ophthalmologist and a rheumatologist to be a basketball team?
Basketball teams do the best when nobody cares who gets the credit, right? When the success of the team, or in this case, the success of the patient, is paramount to any individual person's sort of individual goals. So I was taught when I was in medical school that the most important characteristics of a good physician are the 3 A's. So there's affability. I like to think I'm an affable guy. Availability and ability. Well, I like to think that I'm well trained and that I'm affable, but in terms of making a good team approach, I have to be available to the patients. I have to be available to the people that are helping me take care of the patients. And the teamwork works well when we pass the ball back and forth well to each other, when we're both playing defense, when we're both doing the things that are necessary to make sure that we're available to each other to freely share information so that we can utilize our various strengths. I can tell you from my experience, you're a better shooter than I am.
Not true.
But yeah, so you know, I've got to put you in a success as a passer or as an all-around player to where you like to shoot, and vice versa. You know I like to drive to the hole, so you set me up in ways that I can be successful as well. So you know, ophthalmologists have a certain skill set that rheumatologists don't routinely possess, and vice versa. So I used to always say that Dr. Rosenbaum and I are like a perfect yin-yang couple, because I'm an ophthalmologist who thinks he's a rheumatologist, and he's a rheumatologist who thinks he's an ophthalmologist. But recognition of the things that each of us have, the training that each of us have that allow us to do certain things. I'm pretty good at giving people immune suppression, but Dr. Rosenbaum has the training and the expertise to have a greater realm of expertise in that area. And not only in that, but in assessing the non-ophthalmic systemic inflammatory conditions that patients also have. In terms of diagnosis and differential diagnosis, Dr. Rosenbaum's tops of the tops, but in terms of being able to hone that down by knowing where the inflammation is and what the clinical characteristics of the inflammation are, in general, an ophthalmologist is able to help a rheumatologist formulate an appropriate differential diagnosis, and working together we can come up with a good treatment strategy that sort of incorporates all the things we've talked about based on taking advantage of the things we both do well.
So what have you found that works? What are the strategies that you use to communicate with the rheumatologist?
Yeah, so of course I'm lucky that in many circumstances I can walk across a hall and tap a rheumatologist on the shoulder. If not yourself, in my other practice at the VA hospital in Portland, I can literally walk across a hall and there's a clinic full of rheumatologists that I can reach. Not everybody's that lucky. With the pediatric rheumatologist that I commonly collaborate with, they're at a different hospital here in town, but I've been lucky to have an incredible relationship with them, and one of them is probably my best texting pen pal. We text back and forth constantly about patients on the days that I'm in clinic, and vice versa. And whether it's texting, whether it's picking up the phone and calling, whether it's going to the next door office or across the hall to find a rheumatologist, I think that, again, that availability piece of the affability, availability, ability, you just make yourself available and they make themselves available, and working out those kind of communication relationships really helps a lot. Email works as well, phone calls, the whole gestalt, the whole 9 yards.
I'm excited about the solution that you and I are planning, which will start in a couple of months, and that is we're going to have an interdisciplinary clinic where physically there'll be a rheumatologist and an ophthalmologist in the same room.
That's an ideal setup, obviously, right? It's great if you can work it out so that you can have an ophthalmologist and a rheumatologist physically available to collaborate on the patient's care in real time. Not everybody's as lucky as we are or as good at basketball. So if you can't develop that, then the next best, obviously the next best scenario would be to create a sort of a virtual simulation of that, where an ophthalmologist who's comfortable evaluating and diagnosing and anatomically classifying uveitis can talk to a rheumatologist who's comfortable immunosuppressing the patient and also doing assessments to sort of suss out the cause and the systemic associated inflammatory findings, so that we can work together to make sure the patients get the great care that we all want to give them.
Yeah, but there certainly are obstacles. I mean, time is an obstacle. Who gets credit? Who makes the decision? Who's compensated? Yeah. Those are pretty big obstacles.
Yeah, and we've all heard stories. So one of the things that we always tell our residents, for example, is the eyes and the joints, or the eyes and other systemic systems that are involved, the gut if you're talking about inflammatory bowel disease, or the lungs if you're talking about sarcoid, they can progress independently, right? And so I think what's important is building a good, collaborative, trusting relationship where I can, and in Portland, Oregon, this isn't a problem because most of the rheumatologists are trained by you, so they get it. But in some places, you just got, you've got to be able to have that communication with your rheumatology colleague and say, hey, I understand the joints are doing great, but the eyes are doing terrible. We need to take it up a notch, and vice versa. If the rheumatologist calls me and I say, hey, the eyes are doing great, and the rheumatologist says, yeah, but the blood count or the liver function's awful and we need to switch to X, Y, or Z, we've got to be able to go back and forth and work together. Because the most important person isn't me or you, right? It's
the patient.
The patient.
Yes. Many rheumatologists love that our specialty requires us to know the heart and the skin and the muscle and the bone and the lung and the liver. And so at Oregon Health and Science University, we've established interdisciplinary clinics for nerve and muscle disease, for interstitial lung disease, for cutaneous disease like psoriasis and lupus, and ophthalmology, uveitis, scleritis, orbital disease. It's the perfect interdisciplinary clinic.
I couldn't agree with you more.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/SYZ860. This activity is supported by an independent educational grant from AbbVie. This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.